Hi, everyone, and welcome to Office Hours. I'm your host, Stuart Newsom, and I really want to thank all of you for spending some time with us today. Today's episode is focused on ensuring quality and compliance in AI coding. So, we're going to keep things a little practical today in our discussion. This isn't your mama's CAC, otherwise known as computer assisted coding. It's autonomous coding. And there's a difference. So trust me, you're going to want to listen in on this. So you'll hear how AI coding can deliver real value without compromising any compliance issues, what safeguards that are built in, and also how leaders can feel confident adopting this type of technology. So I'm joined by two fantastic guests from Maverick Medical AI. We've got Stacy Buck, who's the VP of Coding Compliance, and Michael Bronzino, who's the co-founder and chief commercial officer at Maverick AI. So Stacy brings years of hands-on compliance expertise, as well as Mike has been out there helping organizations understand how to bring autonomous coding into their operations. So how are y'all both doing today?
Great,
We're
great.
doing great.
Awesome, awesome. So I just want to pause for a second before we actually dive in and kind of give, if Mike or Stacy, y'all just give kind of a background on Maverick AI and what exactly the difference is between the I'm going to call it the old technology, but I still think some people think it's the cutting edge technology when it's not. But just kind of give a little background on Maverick and why what are the differences between autonomous coding and CAC.
Sure. I appreciate it, Stuart, and I'm glad to be here. Oftentimes companies will enter into a market, either they've created a technology and then they're looking for a problem, or the right way of doing it, they identify a problem and then create the technology and the solution. And my co-founder, Yossi Shahak, and I saw that in having been in the healthcare industry for both of us 30 some odd years across financial, clinical, and operational solutions, we saw that the area of financial really drove really strong ROIs. Selling in the clinical space, sometimes those are squishy ROIs, but if you've got a financial solution, very strong ROIs. In talking with a number of CFOs, there was a lot of focus on how do we drive efficiency, how do we drive costs down across the revenue cycle. And then as we got a little bit deeper into that conversation, there was a lot of focus on the medical coding piece of that rev cycle. It was one of the most labor intensive, one of the most cost intensive, and in like it or not, one of the areas where a lot of errors were occurring that could cost a healthcare organization quite a bit of money and quite a bit of rework when they're reworking denials. So we saw, okay, there's a problem. How do we drive cost out of the coding operation? So what's the current solution? Well, technology has evolved from just humans doing the coding through their books through to, as you mentioned, computer-assisted coding. And computer-assisted coding's been around, what, Stacy, maybe 15, 20 years?
Probably 20, a
What?
little bit more than 20 years.
Yeah. It's an older technology, and at the time it had great promise. We're going to leverage NLP. We're going to be able to work off of keywords. We're going to build out a number of these rules to address those, and it's going to assist the medical coders to be more efficient. But still, that operative word is assist. They were still having to interact with the system, still having to finalize and do the coding. So there was an opportunity there to say, okay, is there a next generation technology? As with most things, technology is typically, as those evolve, they allow us to do better and better things. And so Yossi and I had an opportunity to investigate some of the transformer-based technologies, some of the technologies that were being leveraged, AI being leveraged with, say, similar to ChatGPT and some of the other text-based AI applications. We saw this as an opportunity to leverage some of the work that was being done in those areas, bring on some data scientists, and then we were also very wise early on to make sure that we were driving our solution from a clinical perspective or from a SME perspective, and we brought Stacy into the organization in the very, very, very beginning. The last thing you want to do is have developers developing a product and then it gets out there, it's like, who did this? But we can't clinically use
Right.
this. And so we made sure we were having the right focus from the very beginning. And we like to say it was a solution developed by coders for coders. So that's what got us there. We saw the problem. We saw an opportunity to leverage the latest and greatest technologies in these AI transformers, and we looked to solve the problem. And we've been very fortunate that in solving that problem, we've been able to drive cost out of the operation with a number of our clients. We've been able to drive efficiency clearly across the coding operation. And most importantly, accuracy and consistency of that accuracy has gone up significantly.
Well, that's awesome. And it's all about outcomes. And we're going to actually peel back the onion, so to speak, on all of this going forward for the next 20, 25 minutes. So everyone, I just want to remind everyone, if you have any questions, you can certainly put them in the chat or in the Q&A box throughout. We will have some time at the end to address your questions. I always remind everyone it's not just questions, it could be comments, it could be insights. So I always want to hear what everybody else has to say, particularly this subject today. So we'll dive into a few questions. Just want to start with, you mentioned, people using CAC, the old-fashioned technology that Stacy mentioned was, 20 years old or so. But still, there's a lot of providers using computer-assisted coding. But CAC often tops out at, say, 30% direct-to-bill rate and leaves huge compliance gaps. How is autonomous coding fundamentally different, and why does that difference matter for radiology compliance? I mean, I know that Mike touched a little bit on that, but I just want to kind of do a deeper dive.
Yeah, sure. Before I get into that, though, I just want to talk a little bit about my personal experience with the CAC coding. The company that I worked for 20 years ago, we were an early adopter of CAC technology. And back then, they set the expectation that 70% of the radiology encounters could be sent direct to bill. And so as a billing company, you're looking for that efficiency. You want to be able to send all those encounters direct to bill. And what we found 3 years into it is we were still reviewing everything 100%. Nothing was going direct to bill.
Right.
And just looking at the experiences of other people in the industry, it seemed that they were all kind of in the same boat, and we really didn't see that return on investment that a lot of us expected. I remember coders were fearful that they would lose their jobs, that the demand for coders would go down. The exact opposite happened. The demand for coders has gone up since that point in time, and it just never delivered. I mean, 30% is probably on average the best you'll see. Every once in a while, you might see a provider hitting close to 50, but that's if they've been using the same CAC for like 10, 15 years, and they have spent a lot of time building rules, hundreds of rules, thousands of rules. And I remember when I first, was approached by Maverick, Yossi, the CEO, he had reached out to me and told me about what they, were wanting to develop and how their platform could deliver, these results of 85% direct to bill. And I got to be honest, I was so skeptical. When I had that initial conversation, I'm like, I just don't see how that's possible. Again, looking back to the experience with CAC, I'm like, now here's a high number that we're hearing, and I just don't know how that's possible. So I'm like, you know what? I'm going to join Maverick. I'm going to work with them to help them build this platform, because I saw that they were, getting that subject matter expertise, from me, and also bringing in other coders as well to work with me to be able to develop the product. So I'm like, okay, they're doing it the right way. And then at first, I didn't quite understand the technology, piece of it. Medical coders have their own language that they speak, and then the developers and the data scientists have their own language. And I had a little bit of trouble understanding like how it all worked. But I can tell you this, I was blown away by the results that they were able to get. So just working in partnership with them, we were able, to have that proof of concept and achieve that 85% direct to bill with 95% accuracy. Within a couple of, I think it was within a couple of years we hit that, because, we had that development time before it was out there in the general public. But I'm like, wow, this is a real thing. And so I was really impressed. And I have to say the Maverick R&D team, I feel like I've been learning more about like their work and what they do. And I feel like some of them are gaining like a lot of coding knowledge, like having worked with me. And it's just been really great working with such a talented team. And, whatever I ask them for, they can make it happen, which is amazing. And coders, if you've worked in coding management positions, for example, you get a little frustrated sometimes where you can't get, information that you want, reports, that type of thing, but they're really great at analyzing data and then
Mm-hmm.
getting me what I need. And they've also done that for the customers. In the product, we have a lot of reports, a lot of analytics. So they've just done a really great job there. So the difference between CAC and autonomous coding, it's not rules based. That's the main difference. I think a lot of people come into the autonomous coding space with that CAC mindset that coding is being done on keywords, and that's actually not how the coding is done. A true autonomous coding solution is going to use your historical data for training. So at Maverick, we typically ask for 2 years worth of historical data. So we take your reports with your codes assigned, and then we train the model with your data. So what happens is the model is learning based on the patterns of the documentation and the codes that are assigned without building rules. Because sometimes the question is, oh my gosh, we spent all this time building these rules in CAC. Are we going to have to start over again and build more rules? And the answer is no. I describe it as those are already baked into the cake. You've been coding in accordance with those rules while using CAC. So that is embedded in your coding patterns with your documentation. And so then the autonomous coding is going to learn from those patterns. So that's really the main difference, is that it's going to learn from what the human coders have produced in the past. And then it also has the ability to look at reports in their full context, in their entirety, and really understand the context of a report to be able to assign the correct code. So that's the very basic overview without getting into it too deep.
Yeah.
Right. And
So,
it sounds,
but
oh, go ahead, Mike.
I was going to add one thing when we talk about the technology, and Stacy mentioned the term models. We often get the question from prospects or other healthcare providers that are looking or exploring the technology. Are you leveraging or using some of the off-the-shelf models? There's a number of commercially available models out there. OpenAI has models. Google has a model. There's a number of them. And the answer is no. Be able to take those. Now, some folks have tried this, and we've talked to as we know, some of those healthcare systems have got those innovation labs, and they will do some experimenting and work there. And they'll say, well, we were able to get it to code this, but to the level of accuracy and the depth of the coding, it just isn't possible with any of those. So we focus very much on creating our models to be very specific to address that specific specialty that we're dealing with.
Yeah, and that's the appropriate approach. I mean, you're building this because it sounds like these are AI coding agents, so to speak, because it's using machine learning models. You're building that that knowledge, that tribal knowledge, if you will, that so many organizations have. It's being transferred into this AI, and we've been talking ad nauseum about AI agents and how it just is so much more dynamic as where it simulates, and well, simulate's not even the right word, but it actually takes on. That's why it's able to take on its a digital coworker to go hand in hand. To your point, Stacy, earlier about how CAC is just an assistant, and you still had to put in, still had to do the work. It even increased the number of coders that needed to be a part of the equation. This is just a whole nother level.
Yeah, what
Um,
we often talk about is think about getting the most highly trained, most proficient medical coder possible, and turning them out on the floor or into the system day number one, and having them be super proficient day number one. And that's what we're doing with our model. There's no
nice.
ramp up time that happens at the customer site. It's this ready, coder's first day of work, they're super proficient. And they
That's
never
awesome.
take vacation. They never ask for sick days off. Work through holidays 24/7.
Right. Now, the big question on everyone's mind, because we hear this from leadership a lot, and I'm a CPCO by trade, or with credentials, so that's where my heart kind of goes. But what safeguards are in place to make sure cases routed direct to bill are accurate from day one? From that perspective, can you walk us through the auditing protocols and exceptions handling that give organizations the confidence to really start with something like this?
Yeah, I can talk about the Maverick process, but before I get into that, first I will say that you will audit AI coding just as you would your human coders. You're either auditing them on a monthly basis or hopefully at least a quarterly basis. I know some providers only do coding audits once a year. I'm like, yeah, you probably need to be doing it a little bit more than that because things can creep up during the course of a year. But you would still have to audit them just as the human coders. Where you have the advantage is that the model is going to code the same types of cases consistently, where we all know with human coders, you can have 10 coders looking at the same documentation, and not all 10 coders are going to come up with the same exact answers potentially, looking at the documentation. So once the AI learns how to code something correctly, it will consistently continue to do so. So as far as our process at Maverick, we are looking at the data, and we actually really start auditing during implementation. When the client sends us the historical data, we run it through the model, and then we look at, okay, where does the model match the historical, data? We consider those encounters coded correctly. And then where does the model differ from the historical data? And that's where I dig into all of those encounters. And then I make the determination, did the model code this correctly, or did the human coder code it correctly? And we've actually found in some cases where there are things that were coded incorrectly by human coders, and we bring it back to the client and we say, hey, we found this and we think this is correct. And they're like, absolutely, we're going to go back, we're going to do some education. And then those areas where the model doesn't match the human coder, that's where we talk with the client and we find out where we need to do customization based on their own internal coding guidelines, that they have. Obviously, those of us who are medical coders, there are a lot of gray areas in coding. And when you go from job to job, I know myself working with different clients all over the country, everybody codes things a little bit differently, based upon, maybe some regional guidelines, some state specific things they might have, payer specific things. But even in general, those areas where we don't have official guidance, then there should be some type of written policy established how to handle those encounters, and that should be adhered to. So at Maverick, we work on that to do any customization. I review any written guidelines that the client has. We talk about any differences of opinion on those, talk about the compliance implications. Ultimately, the client will make the decision on how those encounters are going to be coded. So we're doing that during the implementation process. Then when we go live, which actually I will say is typically 90 days or less from the time of contract signing. So we do implementation very quickly. That first week, the client is typically auditing 100% of what the platform is coding. And that's just to make sure that it is going to meet expectations. We already have a pretty good idea based on the validation process, approximately how much can go direct to bill. We strive to hit that 85%. Sometimes we may not get to the 85%, but that may be because of documentation issues on the end of the client, other things, or maybe the client says, hey, we want certain case types to go to manual. We don't want them to go direct to bill. So it could, for client specific reasons, be a little bit lower than that, but we want to get to that 85%. So the client does the 100% review week 1. And then during that week, I look at all of the changes that the client is making. And then I see where we can make improvements in the model. If there's something that it is consistently coding incorrectly that week, then I make note of that. I go back to the R&D team and then we look at that. And then we can make our little tweaks and changes to the model to get better improvement on that. And then after week 1, the client decides, whether or not they feel comfortable, with sending things direct to bill. And then they decide the percentage that they want to send direct to bill. In the beginning, some are really fast, some are really aggressive, and they're like, let's flip the switch and send it all. And then you have others that are a little bit more cautious, which a past compliance officer myself, I completely understand why some want to go a little bit slower. And so again, we let the client set the pace there. So after week 1, I continue to review all of the changes that are being made. I look at them on a weekly basis. I get a summary of all the changes. And then again, I'm constantly working with R&D to see how we can improve the model. And then I'm also doing quarterly audits for all of the clients for encounters that have gone direct to bill. And that way we make sure that we are also monitoring the ongoing output to make sure nothing has, crept up, nothing has changed, and that we're still seeing that 95% accuracy rate. And at the same time, the client should still be auditing. They have the ability to set the percentage that they want to go to QA. So they can set that, as high or low as they want as far as auditing any of the encounters that go direct to bill.
One of the things that we've done is we've developed a number of pretty robust reporting tools to allow the customer to run a variety of different types of audits. We try to capture all the different ways that folks will audit their organization and their coders and the capabilities of the AI engine. And we've got those reports built into the system. We're finding ourselves doing quite a bit of reporting, development capabilities, because again, the data is there. And if we think about what we're doing, we're here to drive operational efficiency, drive down costs. Okay, let's see how we're doing against that. So a lot of focus has been put on the reporting capabilities lately.
Yeah,
Awesome.
one of the things I love about the platform, being a coding auditor and having conducted audits for, clients all over the country who are on different coding platforms. Everybody has a different coding workflow. You can actually do your auditing in the Maverick platform. There is no manual spread. There aren't any manual spreadsheets. There's nothing like that. It's all done in the platform. And then you can export, the data that you want, and then you could put together a summary, based on that. So I appreciate that as an auditor, that I don't have to create that Excel spreadsheet when I'm auditing encounters. I audit in the platform, and then I can extract that information into a spreadsheet format and then manipulate it as I want to, and then do my summary. So I think that's the coolest thing about the
Yeah.
platform. I've audited on too many CAC platforms
Yeah.
in my career, so I really appreciate that.
I think you
Well,
can
the
hear
reason for
everyone's
that
head
is
explode.
we were super fortunate to, as I said, we looked at the current technology. We had an opportunity to see what was currently out there, had an opportunity to sit with a lot of different customers to understand what do you like, what don't you like, what's your wish list, how would you like this to be, and being able to develop this from scratch with the latest technology capabilities for our user interface and the platform. We get a lot of compliments of, geez, I wish I would have had this before. So
Right, right. And so, we've both of you have talked about, the data quality as well as, the safeguards that are going in here. And I know one of the biggest aspects, because what you just said, Stacy, about auditing within the system, and the capabilities of that, it pretty much has to do that with what I'd like to call continuous improvement. That's
Mhm.
part of the model is continuous improvement. So, unlike static rules-based systems, like, CAC, as you described earlier, autonomous coding models get smarter over time. Like any AI agent,
Mhm.
so to speak, or anything that leverages machine learning models, that's the idea. You're getting smarter over time. So how does that continuous improvement process actually work in practice? Because I think people can hear what you're saying,
Mhm.
and when you describe, the whole auditing process, especially with spreadsheets, I think you probably freaked everybody out. It's like, oh, some people love their spreadsheets, right? But you have to kind of break away from that. But if you could describe
Yeah.
actually how that works in practice, what measures do you use to show coders and compliance officers that accuracy is improving?
Yeah, so I mean, as Mike said, we have a lot of reporting capabilities, in the platform, there. And what's nice about, the autonomous coding is that it learns by the coder feedback. Every time a coder is making changes, then that information is then going to be used to train the model. Now, that's not necessarily going to happen instantaneously, where it's going to change how it codes something. For example, I can tell you, if something's been trained, some clients will decide that they want to change the way they code something when we go live. So they're going to code it differently than how they have for the past 2 years. So in that case, if you've had a particular report that has gone through the system, that identical documentation has 20,000 times, had the same codes assigned to it, and now you introduce a new way of coding, you have a bigger hurdle to overcome because it's seen that other pattern 20,000 times and now you're
Mhm.
introducing a new pattern. So in those cases, we have things that we can do to accelerate that process in the background. And then periodically, they will do retraining of the model. What we really need to see for autonomous coding is enough examples of a particular report for the model to truly learn on its own. But we have the ability to help it along and prod it. I don't really know how they make it all happen in the background. I just tell them what I need it to do and they make it happen. So we can fill that gap for the customer until they actually get enough examples of a report, or then it would learn from that continuous feedback. But I know that periodically they will do retraining of the model and they will do retraining on specific aspects of the model as we do make improvements like for the clients, but it's really mainly reliant on that client feedback. Looking at the changes that they're making on a weekly basis. I look at every change that has a high frequency. That's what we focus on first, and then trying to improve those. And then sometimes if you have new codes that come into existence. Let's say a CPT code has never existed before for a service, or you have a category 3 code and we've never seen that service before. That's one of those instances where we don't have enough examples for training, but we have the ability to like help that along. So we can build some rules in situations like that, but the long term is not going to be rules based. It's a very short term solution to achieve an objective. And then it's just going to continue learning from that feedback loop. But then if a client wants to make a change, then we kind of go back to the drawing board. Oh, there's a new coding clinic out or a new CPT assistant out, and we want to change how we code something. Then we can go in and make those changes and updates, or even with like ICD 10, the changes going into effect October 1st. We review all those way in advance. We do the work in the background. We crosswalk everything we can. And we do the best that we can to take a sample of data and then map the codes so that on October 1st, all of the new codes, the correct codes are being assigned based on the documentation. Short term, you might have a little bit of a bump in how many you see going to manual review just to kind of have, the second set of eyes on there. But all of those things just kind of happen automatically. We are always working behind the scenes, even if the client isn't seeing it. We find things. I know the guys on the R&D team, they're constantly doing data analysis. And if they see something that doesn't look quite right, they'll bring it to me. I'll analyze it. I'll see if there's something that we need to discuss with the client or if we need to make any changes. But I feel like we look at the data and we look at the feedback from every possible angle that we can to achieve that best result.
Yeah, that's awesome.
When we talk about the technology, there's a key piece to that is, as Stacy mentioned, having enough examples, right? And we run into this quite a bit as people think, well, you need lots of data, millions and millions of reports to train these models. Well, it's not just the quantity, it's also the quality, and it's also the number of examples as well. So we identified that very early on, and we, from a technology standpoint, developed the ability to create synthetic data to build out where we may not have enough examples or sample examples, and get that sample size up higher so we can get better results. And that's one of the ways that, from a technology standpoint, that we're addressing some of those gaps where we don't have enough examples.
Sure. And considering all the variances, right? Because you mentioned all the reports.
Yep, and that's what this synthetic data does. It creates reports with a number of different language and a number of different ways that it's being expressed. Again, still creating the same diagnosis, but again, different ways of saying it.
Yeah, especially if you're in a facility that's a very large radiology organization and they have, 50 radiologists, right? Just pick any number. And they all don't document exactly the same way. I mean, they may document similar, right? Keyword, it's similar, not exact. So it has to learn all those variances from all those 50 personas, and then consider how those are coded. And it's all going to the same code, though. It's just like a coder may interpret codes differently from the chart. Well, a provider is going to actually document it differently. So I would imagine this could then sync up, maybe even some documentation improvement opportunities, going back and talking to these providers and making sure that their documentation is up to speed to get where you need to be.
That actually, Stacy can probably talk to that. That happens quite a bit during that early stage of the implementation, where we're bringing in the period X number of months of reports in, and she begins to look at those, and things do pop up. There's some documentation issues that often have to be addressed, and be able to address those up front before the system is live is really, really helpful.
Yeah,
Right.
that's part of the analysis where I look at deficiencies in documentation. And in radiology, unfortunately, there still remain a lot of documentation deficiencies. And looking at those reports, when people ask, can AI code this or that? I tell them if it's documented in the report, it can code it. If it's not documented in the report, then you're not really going to get the most benefit out of the autonomous coding solution, because it doesn't have the language associated with the code. And those are the types of things I noticed during validation. I look at the report and I see multiple codes assigned, and I'm like, okay, well, not all these codes are documented in the report. For example, diagnosis codes. I'm like, where did this come from? Odds are the coder had to go look outside of the radiology report, pull a test order, and then assign a diagnosis code there. So it creates the situation where the model could be seeing an incorrect pattern. It's making a wrong association based on the historical data if you have certain types of cases where that's problematic. And I know there are several types that are problematic. So whenever I talk to people about, who are considering autonomous coding, some people are looking at it now, some people are considering it a year or two from now. The time to do documentation improvement is now. Even if you're not at the point, the sooner you do it, the better, because the documentation improvement now will, lead to better coding now, and then that's going to be better historical data for model training, and you're going to get a better result. And what we find in working with clients is that they have been trying to get their radiologists to change some of their documentation patterns over the years, and sometimes they're resistant to do so. They're just very set in their ways and how they document, or they have some workflow issues that they kind of get some pushback on. When they go to leadership and they explain, to get the best ROI for the autonomous coding solution, we really need to have, these documentation improvement initiatives. And I'm actually finding that a lot of them are being successful in getting that buy-in that they weren't getting before. Not everybody falls into line, and not every provider, gives us perfectly what we want. But I find that leadership likes to kind of have a little bit more leverage. And when that's coming, from us, and we're making this recommendation and we're showing how it affects the ROI, then they're more likely to actually engage in documentation improvement initiatives.
Right, right. And so, and I know another issue regarding compliance, us compliance officers are always concerned with the black box effect, right? Not knowing why the AI chose a certain code. Kind of have, like, I think you spoke to that a little bit earlier about the audit trail. How important, is that transparency and explainability in vendor selection? What should leaders expect to see in an audit trail to feel confident about the compliance?
So
Yeah.
let me start that, Stacy, and then you can dig into the compliance. So I'll start from the user interface first. So as I said earlier, we had an opportunity to sit down with a lot of folks to really kind of understand how should we build our requirements documents as we develop this glass box approach. So you mentioned black box, Stuart, and black box, when you think about that, is the report came in, the engine coded it, and then it exported the coding data out to the billing system. How do I know what even happened? So we knew there had to be a glass box approach, which then creating a user interface. That user interface serves a number of purposes. We often call it we talked about the auditing capabilities there, but it also gives you a capability to code as well. And what happens, and I don't have the ability to show it, but when you say, how do I know where that code was derived? We actually will color code on the report as they bring it up in the user interface, corresponding to the types of code. So say, for instance, yellow for CPT and green for ICD-10 and red for or pink for supply codes and so forth. So they can see very quickly this code was derived from this part of the clinical documentation. And that is always kept that way. So from an auditing standpoint, you can go back and see where this code was derived from based upon the clinical documentation and where it's highlighted.
Nice.
Yeah, I mean, it's similar to CAC in that respect, only it's better than what CAC does, because CAC doesn't necessarily always pick up like all of the keywords and the things that like should be coded. So it has the ability to do that. The other thing that I like in the user interface is that you have the ability to view the coding in multiple layers. So we have what we call the input layer, which that is the CPT code that is sent over from the client. That typically comes from like RIS. Then you will see what we call our encoder layer, which is what the engine codes. Then we have another layer called the post processor, which would be any customization that we do, any payer specific rules that occur in that layer. And then a fourth layer that exists if the coder made any changes is that coder layer. So you actually have the ability on any encounter when you're in it to view all four of those layers. So you can click on it and see the audit trail, a summary of that, or if you just want to click through and see how the coding changed in the process, I think that that's very helpful. So you can actually kind of see the logic of how something is coded. And then that also helps us determine, okay, is this something, at the engine level that we have to make an adjustment to, or is this something, in the post processor, layer where we have some customization, or maybe we need to do some work there. So I really like that transparency where you can see, what is generating the code at every level. And one of the reasons for bringing in the input code from the client, even it may not be correct coming in from RIS, or often there's more to code. If there's a mismatch between what's coming in from RIS and then what the engine codes, those actually get routed to manual review. So that's kind of like another check. Most of the encounters, like I said earlier, 85% direct to bill for our clients is, that target where we're at. Those other 15% will fall out for different reasons. It might be if there is a mismatch on something like that. If for some reason the model just doesn't understand the report, for whatever reason, maybe it hasn't seen enough examples, that would get routed. The other things that get routed would be anything that has an NCCI edit, that would go to manual review. Anything that hits an LCD edit, if you have an excludes one, excludes two note, shouldn't really see a lot of those because the engine should know how to code those. Those are really there more for if the coder is making a change and then they're trying to assign a code, then they'll get an excludes one, excludes two note notification there. And then complex IR gets routed to obviously like a manual bucket. So there's not a lot of reasons for it to go over to that manual bucket. So those are the typical ones that you would see in that 15% that are not coded by the engine.
Nice. Wow. Awesome. Well, that's all the questions I have. We are running a bit over, but that's okay. This is important. This is interesting stuff. And we do have a couple of questions that are in the Q&A. And one, kind of speaks to, let's see, I'm just going to read it. From sites that are live, what portion of cases can be effectively and safely handled fully autonomously by AI coding agents?
Yeah,
So
so
I'll be happy. I'll be happy to take that because I do the reports every month. I will tell you that we have a client that's doing 92% direct to bill as of last month, and our lowest level is 85% direct to bill. So it ranges between 85% to 92% direct to bill.
Yeah,
Yeah,
that's
one
nice.
thing, one thing I would like to add that I think speaks to all the work that has gone into the product is that on occasion you may run into someone where you cannot use their historical data because the quality is so poor for whatever reason. And what I have observed when we do not use a client's data for training, we just apply the model to their reports, we can achieve approximately 70% direct to bill with no customized training. So I think that's pretty impressive, and that speaks to the robustness of that model and all the tens of millions. I don't know, Mike, do you have any idea how many reports have gone through? I mean, it's got to be, I don't know.
We're probably up over getting close to 20, in excess of 25 million. We might even hit the 30 million.
We're
mark.
more than that. I know we're more than that. It's been a lot.
So many you can't even count, right?
Yeah, I like lost count at like some point. No, I believe it's more than 25 million at
It's
this
probably
point.
it definitely is north of that. The last time I counted, we were around 30, and it's been a while. So
Yeah, so I think, well, yeah, I'm also considering other training, that other reports that have gone through that are not live with our clients. So if you take and say if it's 30 million currently, that we do, and then you add in the others, it's been tens and tens of millions it's been trained on.
yeah,
So
yeah. I was
yeah,
kind of addressing the production
yeah,
volume. Yeah. No,
Gotcha.
you go back. Oh yeah, it's in the yes. It's a lot. It's a
A
lot.
lot of
It
data.
kind of goes to, I see the questions up there, and one of them is around the language model and whether we can use Sonnet or ChatGPT 5. And I kind of addressed that during the discussion is those particular large language models that were developed there are not developed around and utilizing all of the clinical data and the tens and tens of millions and millions of radiology reports that we use to develop our language models. So the short answer is no. And we have developed our own specifically to be able to address radiology at the level of direct to bill and accuracy rates we're getting.
Right, right. That's a good point because there's just so many nuances.
Yeah.
Typically, those models can't really comprehend or understand even with all the
Yeah.
training. So it's really smart to build a unique model specifically for the use cases that are here.
And those models are not real time. So those
Right,
models are snapshots in time that the data is snapshot in this time data that's been used to develop that model. So it's not an ongoing, it's up to date last whatever
right,
happened across the web in the universe yesterday is not captured in those models.
right.
Yeah.
Exactly.
You also have to consider that you have proprietary information, CPT codes, right? Proprietary information that is not publicly available and wouldn't be anywhere else. So to
Yeah,
just pull, that's the problem right there.
just got to pay the AMA that fee, right?
I know, they got to get their
Yes, we
money.
do. Yes, we do. But you know
Yeah.
what? They give us great information to be able to keep the models going. So
Exactly, exactly. It's awesome. Yeah, awesome. Well, I know we're over. There are, a couple more questions. Just apologize for not being able to get to those, but I do want to thank Stacy and Mike for y'all coming on board. Stay tuned. We are going to have them on again. So if you didn't get your question answered now, look out for some registrations for another upcoming office hours that they will be a part of, likely next month. We're looking for a time spot in October to continue the discussion, maybe even on other topic. Today was more about compliance, but we're going to probably talk about a little bit more other nuances that are involved in this space. So thank you both for coming on board.
thank you for
Awesome.
having us,
Thank you.
Stuart.
Yep. And thanks everyone for joining us. We had a really good crowd today. Really appreciate everyone taking your time and especially staying over with us. Just want to invite you to come see us next week for another episode of Office Hours. So we'll see you then.